I'm Dr. Stephen M. Stahl, Professor of Psychiatry at the University of California, San Diego, Honorary Visiting Senior Fellow at the University of Cambridge, and the Director of Psychopharmacology for the California Department of State Hospitals. Joining me here today is Dr. Richard Jackson, Diplomat of the American Board of Psychiatry and Neurology, Associate Clinical Professor of Psychiatry at the Wayne State University School of Medicine, and Assistant Clinical Adjunct Professor of Psychiatry at the University of Michigan Medical School.
Today we will be discussing methods for differentiating between tardive dyskinesia, or TD, versus drug-induced Parkinsonism so they can be appropriately treated.
So, what are some of the key distinguishing clinical features in the presentation of TD and drug-induced Parkinsonism?
In clinical practice, differentiating between TD and drug-induced Parkinsonism can be challenging, as the symptoms may look very similar. For example, this individual exhibits tongue movements that appear like a rhythmic tremor occurring at a relatively continuous speed, and he was diagnosed with drug-induced Parkinsonism. By contrast, this individual has tongue movements that are not rhythmic and differ in speed. In fact, towards the end of the clip, he actually bites his own tongue. This is an example of TD. Steve, can you share with us your approach to differentiating TD from drug-induced Parkinsonism?
There are several factors that can come into play. The first is history, or time of symptom onset relative to when the medication was initiated, which is influenced by the mechanism of disease. In addition to this, there is the physical exam. And finally, significant insights into whether or not your diagnosis is correct can be gained by observing the response to treatment, though antipsychotic dose adjustment should not be made for the sole purpose of differentiation. Let's begin by reviewing the DSM-5 criteria for TD and drug-induced Parkinsonism. The DSM-5 defines TD as involuntary, athetoid, or choreiform movements, generally of the tongue, lower face, and jaw, and extremities, that develop after use of a neuroleptic for at least a few months. It does specify that symptoms may develop earlier in the elderly. Finally, it specifies that if symptoms persist for longer than 4 to 8 weeks, then it is considered to be tardive dyskinesia. By contrast, the DSM-5 defines drug or neuroleptic-induced Parkinsonism as Parkinsonian tremor, muscular rigidity, akinesia or bradykinesia that develops within a few weeks of starting or increasing the dose of a neuroleptic or reducing the dosage of an anticholinergic.
While the DSM does provide some guidance and history can be a good guide, there is some gray area when differentiating these conditions based on the onset of symptoms. This is where the physical exam can provide some insights in the differential diagnosis. TD can be evaluated and diagnosed by a careful physical examination using the Abnormal Involuntary Movement Scale, or AIMS. The AIMS consists of 12 questions on a 5-point rating scale, ranging from none to severe. The questions address involuntary oral facial movements, truncal movements, and limb movements. In addition, there is a score for global severity of movement and for the patient's awareness of abnormal movements. I typically observe the patient as they walk into the office for signs of involuntary movements. Patients can sometimes suppress TD movements or mask them with voluntary movements. It is therefore useful to evaluate the patients unobtrusively before the formal exam begins. During the exam, when the patient is seated, it may be helpful to have the patient seated in a hard, armless chair with his or her shoes and socks removed, so movements of the arms, hands, and feet can be observed.
Do you ever use any other tricks to help unmask tardive dyskinesia movements?
Yes, I have found that many different body regions should be assessed for movements, including orofacial movements, such as puckering, grimacing, and tongue protrusion, truncal movements, and limb movements. These involuntary movements should also be investigated in a variety of contexts, such as at rest or walking, or during activation maneuvers. Asking the individual to perform activation maneuvers, such as performing mental tasks or performing rapid alternating hand movements, like touching the index finger and the thumb, can be helpful in revealing involuntary movements as seen with this individual. In addition, it's helpful to assess involuntary movements in one body region while the patient performs a task involving other body regions. For example, a patient may be asked to hold their mouth open while tapping their thumb and forefinger together on both hands. In this case, the tongue and face would be observed, but not their hands.
I agree with you. Due to its simple design, the aims can be easily integrated into the routine evaluation of patients in the clinic. I typically evaluate patients before initiating a treatment with antipsychotics to obtain a baseline for involuntary movements.
Absolutely. Getting a baseline aims is routine in my clinic. You mentioned that you also use response to treatment as a way of differentiating between TD and drug-induced Parkinsonism, right?
Yes, I find this approach very helpful since patients with drug-induced Parkinsonism and TD respond very differently to antipsychotic treatment. For example, adjusting the dose or potency of the antipsychotic will yield very different responses in individuals with TD versus those with drug-induced Parkinsonism. Remember, these conditions are actually thought to be the result of two opposing mechanisms. Increasing the dose of the antipsychotic may worsen the symptoms in individuals with drug-induced Parkinsonism, but in individuals with TD, increasing the antipsychotic dose may result in temporary symptom improvement. This is because the increased antipsychotic dose will enable blockade of more dopamine D2 receptors, which may inhibit the abnormal dyskinetic movements and therefore mask or suppress TD. However, increasing the dose of the antipsychotic is generally not effective in the long run, since the TD may worsen and the patient is exposed to an increased risk for adverse events. By contrast, discontinuing or decreasing the antipsychotic dose or potency may improve or resolve drug-induced Parkinsonism but worsen TD symptoms. The worsening in TD symptoms may result from a reduction in the number of blocked D2 receptors in the dorsal striatum and an increase in dopamine binding these receptors.
Using these various factors, history, physical exam, and response to treatment to make a diagnosis, an appropriate treatment regimen can be prescribed. It is important to differentiate between TD and drug-induced Parkinsonism to assure appropriate management of the conditions, since treatment for one disorder may worsen the other. For example, VMAT2 inhibitors approved for TD treatment should not be used to treat drug-induced Parkinsonism. Additionally, in some cases, the use of anticholinergics approved for the treatment of drug-induced Parkinsonism in individuals with TD can actually worsen their TD symptoms.
It is also important to closely monitor the patient's response to the treatment. Patients may simply not respond to the wrong treatment, or symptoms may even worsen. If you don't get the response to treatment that you expect, it is always advisable to take a step back and reconsider your original diagnosis.
Absolutely. With every intervention, additional information is gathered which can inform your diagnosis. Let's summarize what we discussed today. TD and drug-induced Parkinsonism can be differentiated on 3 levels, including via history, physical exam, and response to treatment. TD and drug-induced Parkinsonism are thought to result from different medical histories, including length of time that a patient is on an antipsychotic medication, the duration of symptoms, and the age of the patient. Typically, TD develops following use of antipsychotic medications for a few months, with symptoms lasting between 4 to 8 weeks, frequently occurring earlier in the elderly. Drug-induced Parkinsonism, however, develops following use of antipsychotic medications for only a few weeks. Furthermore, whereas a physical exam for a TD patient may expose athetoid or coriform movements, a physical exam for a patient with drug-induced Parkinsonism may expose Parkinsonian tremors, muscular rigidity, akinesia, or bradykinesia. Lastly, TD patients and patients with drug-induced Parkinsonism will likely respond to antipsychotic treatments differently, which may aid in differentiating the two conditions. For example, increasing the dose of antipsychotic medications may worsen drug-induced Parkinsonism, but may temporarily mask TD with worsening symptoms over time. Decreasing the dose of antipsychotic medications may worsen or improve drug-induced Parkinsonism, whereas it may only worsen TD.
I hope you enjoyed our discussion as much as we did. Thank you for listening.